my mind is on the dog. The fact that you've not mentioned it.
That's one. Excellent.
No, this is
how we get them.
The fact that you've mentioned the D word and sensitized me to thinking about the D species is your fault.
It's part of our plan.
Yeah, okay, I'm
it's
ready.
part of our plan.
Sorry for saying Sorry Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Yola Kerpenstein, talented surgeon and social media geek.
Hello, this is Dr. Yola Kerpenstein.
And this is Dr. Susan Little.
Hey, Susan, where are we?
We are in New York City.
New York City.
Home of
love it.
oysters.
We love our oysters in New York City. How many did we have yesterday?
Yesterday, I think we're only at 3 dozen, I think, so far.
Yeah.
We're only at 3 dozen.
Tonight, again.
I've got some catching up to do,
You
I
do.
guess.
Yeah. And we have a wonderful guest here, and that's Dr. Stanley Marks.
Good morning, everybody.
Oh.
How do you know
morning
it's
where
morning?
you are.
Yeah, exactly.
Well, it's 7 a.m. California time, and if you want to even go further back, Bangkok, Thailand is actually 14 hours ahead of California, and that's where I am still. After having just got back from a fantastic meeting.
A GI meeting.
A gastroenterology conference, indeed.
That's excellent.
How cool.
4 days of diarrhea and vomiting. That is cool.
What could be better?
I was in my element.
What
I'm
could
just
be
telling
better?
you. A little bit of jaundice in between, though, actually, just to balance things out.
Really? You get jaundice from diarrhea?
Well, no, the liver is an
Oh.
important organ. And that can certainly
Of
be
the
such a
GI
jaundice. And pancreatitis, too.
Yeah,
There
exactly.
you
As
go.
a surgeon,
As
As a surgeon,
you know,
he should know this.
Yeah, we rip them out. That's it's easy. We
So-
focus on them all the time,
Yeah.
just to take them out.
So
well,
you're
in
gonna-
medicine, we try and preserve these organs.
We do. You're going to hear a little bit of like medicine versus surgery, I'm
No,
guessing.
never.
Yeah.
I
Surgeon,
doubt it.
medic.
I'm looking forward to
You
it.
know, you might.
I'm looking forward to
He
that.
is freaking triple boarded.
Okay, easy on. Yes, he is. But
I didn't say the F word. It was. the
No,
other
no,
word.
that's fantastic. Yeah.
Yeah.
No.
So
You
Stan, how we start with this podcast normally is that you give a little bit of background
Yeah.
of yourself.
Who are you, Stan?
Wow.
Yeah, who are you?
Who am I? I am a intact
Triple-border.
Caucasian. No, I am a. I've got to be careful what I say in this podcast here, boy. But I am a veterinarian, and I am on faculty, professor at the University of California at Davis. I have been on faculty at the university for the last 23 years.
You're
And-
that old?
Well,
You
we
look
graduate
great.
when we are 17.
We were 12.
We graduate when we're 17 at the University of Pretoria, but actually born and raised in Cape Town, South Africa.
We'd never guess, really.
No, my accent's Americanized. But I went to veterinary school at the University of Pretoria, which is the single vet school in South Africa at the moment. And then right after graduating, I elected to come overseas. Initially, it was just to do an internship, and I had every intention of going back home and living a beautiful life in Cape Town, right by the ocean. However, the internship, which was amazing at the University of Missouri, Columbia, led me on to pursuing a medicine residency at the University of Florida. And in those days,
This is number one.
But in those days, it should be emphasized that the residency programs were actually 2 years, not 3 years
Oh,
or even
really?
4 years, as most of the residencies are, depending on what program you're talking about. So 2 years of a medicine residency at the University of Florida in Gainesville, awesome program, loved the school.
Ka-ching.
Ka-ching. And then oncology residency at UC Davis. And in those days, we didn't have a separate oncology service in medicine at UF. And I thought that oncology was a pivotal piece of medicine, essentially, because we saw so much oncology as a medicine resident. And I do feel that my residency at UC Davis really rounded me and made me a better clinician, a better internist.
And that's number two.
That was number two. And, you know, it's just amazing how you talk about timing, you talk about location, and you know, all the cards lined up, because I began to do some research with an incredible scientist, Quentin Rogers, who's arguably the world's most renowned feline nutritionist.
Yep.
And we were doing some projects looking at amino acids in cats with a variety of malignancies. We looked at taurine in some other models, and I began to recognize that a PhD with a residency in nutrition was going to be not only a critically important layer to my training, but also would be pivotal for gaining entry into academia, into a university environment. So nutrition, residency, and PhD, ka-ching, you would
Number
say.
3.
at
Excellent.
UC Davis, and fast forward, I'm faculty there where I'm in medicine, and I'm a current chief of service, and my focus actually, literally 95% plus of what I see and what I do is in gastroenterology, which is awesome. So it's a little bit unique in that some of the other universities, as an internist, you'll do a little bit of everything, but we're quite fortunate at UC Davis, a large cadre of amazing faculty, and a lot of us are able to do and see patients that are only within our specific area of interest. So we've got an amazing caseload, a lot of feline GI disease, amazing substrate for teaching and for clinical research as well. And I'm really stoked to be here today to talk about a little part of that.
Yeah, well, we want to talk about feline GI disease.
Yes, but before we go there, so I always think about the time that I started as a student and I finished my last exam, which was the ACVS exam, I hope, except for my driver's test that I almost failed in Kansas.
Yeah.
But so how long did it take you from the start that you went to university for the first time until you finished your third?
Wow. Okay. That's an interesting question. I've actually never been asked that question, and it's going to require some
thinking,
some incredible
some math,
backtracking. But really
probably.
quickly, when we go to veterinary school in South Africa, similar to Australasia and the UK, you actually are able to go to vet school right after graduating from high school. Now, the things have changed. A lot of the schools are requiring a bachelor's degree, for example. So, at the age of literally 17, 18, you are embarking upon your veterinary training. So I got my veterinary degree at the age of, just under 23. And I was able to be boarded in the 3 disciplines of medicine and nutrition and oncology, and have my PhD when I was 31. So about 8 or 9 years is what it took. Yeah, I did. I took the bullet train.
Indeed.
And
Indeed.
actually, I was lucky because I was able to do these exams in successive years for the most part. But yeah, I mean, it was just
I see a lot of late nights and caffeine.
a lot of that's no, it's not healthy. But yeah, I was very lucky.
That's
and,
awesome. That's awesome.
Yeah.
All right, let's talk about cats.
Yeah, feline GI disease. So, as you know, Stan, I have 2 cat-only clinics, and not just some days, many days, I feel like I have a GI clinic. It's such a common problem, whether it's like acute diarrheas or chronic enteropathies. It's such a common problem.
Right.
So you're in referral practice.
Correct.
And I'm a mixed first opinion and referral practice.
Yep.
So I'm just interested in, because we have 2 different practices, what's the most common cases that get referred to you, like versus what I might see in our first opinion?
That's a great question.
Yeah.
Well, I'm going to take a step back for a minute, just because we do have a very large and growing community practice at UC Davis. And in fact, just as a reflection of student training, the administrators have recognized the importance of students becoming familiar with common medical issues that affect cats and are often seen as an outpatient. And in addition, of equal importance, the types of surgeries that our surgeons in the university were doing and are doing are really of no clinical relevance to most of the students who are going to be in general practice. And in light of that, we've implemented a community surgery practice too, which is an amazing practice, and it's really popular with the students because they get hands in and they do amazing procedures, enterotomies, cystotomies,
Practical stuff.
amputations, absolutely, yeah, very practical. So for me, though, as a tertiary referral hospital, the types of feline gastroenterology cases that I tend to see are those that are typically refractory to conventional therapy. So a veterinarian in practice has seen a feline patient, it has a chronic enteropathy of some sort, the diarrhea has not responded or resolved accordingly to dietary therapy, maybe even immunotherapy, and the animal is losing weight, it's becoming hyporectic, and it needs a second opinion. Or a patient who has really severe clinical signs, a cat that might have triditis as a consequence of severe pancreatitis with a concurrent hepatopathy and an enteropathy, and the cat's clinically jaundiced, it hasn't eaten now for 14 days, and that type of patient actually might even be brought in directly by the owner. I mean, I would simply say that for myself, maybe 2/3 of the feline patients that I see are referral, and about 1/3 are going to be those that are brought in directly by the pet owner, as they can do 24/7 because of our emergency service as well. And so they'll get triaged into the medicine service the following day. But I think a lot of it's chronic enteropathies that are refractory, triaditis, where one needs to get a better assessment of what's going on in multiple organs or tissues, and or an owner who's interested in alternate therapy that may not be routinely offered in a general practice setting. They've maybe read about something online, they want to know more about stem cell therapy or a fecal transplant, and I am very nervous of giving my beautiful cat corticosteroids because I've heard about the adverse effects of said drug, or I've been on steroids myself and I had the worst side effects, and I don't want my cat to go through that. Those are probably sort of the main buckets that I would think of.
And we go in this podcast from left to right, so don't be
I love that. No, I'm getting good exercise for my neck muscles right now.
Exactly. But you were talking fecal transplants in cats? So talk to me about it.
Yeah, of course. Well, I think there's definitely an increased awareness of the role of the intestinal microbiome in health and disease. Not just health for the intestinal tract, health for the brain even. I mean, the gut-brain axis is hugely important. There's a lot of interest in people even now with Parkinson's disease, for example. But, you know, we and many other colleagues have done some really, really good research looking at the advent of probiotics, where you can give a capsule or a sachet of beneficial bacteria to an animal in an effort to try and manipulate or modulate the microbiome. And these probiotics can be single strain, multi-strain, and the goal there is to have these bacteria colonize the distal small bowel and colon in an effort to change the microbiome in a beneficial fashion and then exert a beneficial influence on the host. And I think that the results with probiotics, at least for chronic enteropathies, have been mixed, if I were to sort of say it somewhat accurately at this juncture anyway. And most of the research that's been well published now is looking at acute diarrheas in general. And unfortunately, there's a dearth of really good research studies that have been published in the peer-reviewed literature looking at the utility or the outcome of cats with chronic enteropathies and probiotics. And there's been a lot of interest in a more natural route of using a fecal transplant, so collecting.
So before you go there, because I see you now running around
Yes.
in the wood,
Yes.
looking for cat poop, putting it in your little bag, stamping it down at home,
Yes.
mixing it with some water,
Indeed.
and
In a blender.
In a blender. Sounds really cool.
Yeah, that blender is well used. I'm going to say that.
And
I mean,
well labeled.
and well labeled. No, it's the same one. I mean, it's all healthy. You know, it's all. But
This episode is made possible by the generous sponsorship of the Take the Pledge Against Struvites in Pets Facebook page. Did you know there are 3 easy steps to treat bladder stones in cats with lower urinary tract signs? Step 1 is to take a radiograph, and if there is a stone present in the bladder, step 2 is to use the Minnesota Urolith app for iPhone and Android to determine the most likely type of stone. Step 3 is to treat the cat for at least 2 to 3 weeks with an appropriate diet and see if the stone gets smaller. If so, keep feeding that diet until the stone is completely gone on follow-up radiographs. If not, check compliance with the owner and look for alternative treatment options. Join veterinarians worldwide to take the pledge not to remove struvite stones by surgery anymore.
But actually, there's a couple of different ways that one can actually go about implementing fecal transplantation in the practice setting, and that's what we've done at the university. What you do is you identify a healthy universal donor. This is an animal that's been well screened for a slew of different pathogens. It is a cat that is not obese. It is a cat that has not had any pertinent medical history, certainly no gastrointestinal signs, a cat that has not been on antibiotic therapy or immunotherapy, no immune disease that we are aware of, and the cat would be evaluated and assessed, and we would be then collecting some fresh feces from that cat and screening it for a variety of important enteropathogens. And if that cat is ultimately proven to be a healthy cat and owner or student is willing to facilitate us using their cat, then we can actually set up a situation really where that owner brings us a relatively fresh fecal specimen from home environment within.
So it's non-invasive.
So it's non-invasive at all. I mean, we need enough stool to do that procedure. So, the rule of thumb in general is if we can get that stool within 2 hours, 3 hours, into the recipient, we're good. And there actually is also a company now in San Francisco that has been looking at the advent of fecal capsules. So these are lyophilized fecal specimens that have also been derived from healthy donors. And the beauty of the capsule is that you can use it whenever you want, and then the owner gets the capsules, and they give 2 capsules per day for 2 or 3 weeks. That's given by mouth. That's a good point. I should have clarified that. So the capsules are clean and are given by mouth, and I honestly do believe that probably is the future. The future, though, I will say that it has to be changed in an important way, because at the moment we, and I'm saying collectively we, the profession, is not doing a really, really thorough job looking at the genotype of the donor and looking at or sequencing the stool or the microbiome of the recipient to see, hey, is this the best donor for this particular patient that has this type of disease and that microbiome? At the moment, we're taking this universal donor, who's this golden goose, healthy animal, no diarrhea, amazing lack of enteropathogens that we test for at least, and we use that in all animals, regardless of what the underlying cause for the enteropathy might be. And I don't think that that's the optimal approach to go. But the fecal capsules given by mouth, the transplant that we're talking about, where we're using fresh feces, will be given with a red rubber catheter.
So how do you prepare the cat? Because the cat is probably diseased, and then you cannot just put it in there, I guess. Or?
You will be amazed. Really? I mean, what we used to do in about 2-3 years ago was we would perform general anesthesia for all of these animals, and we would then administer the fecal transplant via colonoscopy. And the benefit of that would be you're getting feces right up into the ileum, and then you can basically essentially administer your slurry of feces all the way down into proximal, transverse, and descending colon, and the animal is essentially raised. So the butt is sort of positioned such that
rear end up
40-degree angle or so, rear end up, so gravity.
So it's not like you pull out the scope and everything
precisely
comes out.
Precisely.
Because you want contact.
You want contact, and the bacteria will migrate. They will move from the colon, where you are essentially transplanting them, into the small bowel. It's pretty impressive. That's been well shown in people as well.
It's like little salmon on the river.
Little salmon going upstream. Exactly. But what I was going to mention is that, a lot of colleagues have recognized now that the anesthesia model with colonoscopy is really not necessary. And a lot of colleagues have simply used a red rubber catheter, either with light sedation
or nothing,
or none at all.
And just giving an enema, I guess.
Just giving it as an enema.
Giving an enema.
And the other thing I'll say too is that we no longer are advocating giving these feline patients lukewarm water enemas or any other solution to evacuate their bowel. We are simply going ahead and passing a red rubber catheter up into the descending colon and going ahead and using your magic.
But you have to make a slurry, I hope.
Correct. We make a slurry.
Do you
Hence
warm
the
it
blender.
up, or
So we need details.
Okay.
Yeah.
All right.
But a lot of vets are listening. There's vets from all over the world that probably are interested in the technique. So
And you can't look this up. Like as you say, currently there's a lack of
nothing.
literature. So we're just kind of interested.
You get so the client is rushing in with his little plastic bag and his fresh 2-hour sample, and
so it's
gives
still
it to you.
It's still warm and steaming in the bag. Yes, it is. Oh, just a little bit. Yeah. It's tepid. It's like your coffee right now.
It's just like coffee.
But what we do, I mean, obviously we can do this in a lab under a hood. This is not something that is essential in a clinical practice setting where a lot of veterinarians may not have access to a hood. But we would take that fecal specimen and we would mix it with 0.9% saline. Key point that this saline must not be bacteriostatic saline.
That makes
because
sense.
if you use bacteriostatic saline, you are going to
defeats the purpose.
You're going to defeat the purpose, and those bacteria are not going to be so happy. So we would mix saline with the freshly procured fecal specimen into a slurry, and we would then filter that slurry through a tea strainer. Essentially what we're trying to do is just remove particulate matter, hair, etc., to make it even a thinner slurry or gruel, and then that would be put into a 60 ml syringe. Just reflux. That would be put into a 60 ml syringe, and roughly for a cat we're looking at about 10 mils per kilogram body weight of a slurry that we'd be giving. So
like 50 mils.
50 mils, beautiful.
One treatment or multiple treatments?
Good question. What's sort of embarrassing is that we don't have the answer to that question. We don't know. I mean, if I look at the human literature, which we tend to do oftentimes to sort of see, well, what are they doing on the human side of things? I think it's being increasingly recognized that for chronic enteropathies, so for IBD in general, multiple fecal transplants is ultimately the way to go. That giving a single fecal transplant is not optimal from the standpoint of getting a long-term benefit. That being said, in human medicine, there is provocative evidence published in the peer-reviewed literature, including the New England Journal of Medicine, a pretty impressive journal, where the single administration of a fecal transplant or even a second can cure over 90% of human patients with recurrent C. difficile infection.
And that's a tough model, right?
Precisely. But what I want to stress is that recurrent C. diff in a human patient is a very different beast or animal to inflammatory bowel disease or a chronic enteropathy that we're seeing in a cat. And yes, there's certainly anecdotal evidence from colleagues in practice who've said, I gave a cat a single transplant and it was awesome. No problem with its stool thereafter. And that's going to be true in some animals. But I'll simply say that if you could give 3 transplants every second or third day, regardless of what the cat's doing response-wise to the first or second from the same donor, I think that would be a superior way to go.
So we've been talking about this in the context of common feline chronic enteropathies. A lot of those would fall under the IBD umbrella.
Yes.
Right?
Yeah.
So let's just switch gears for a minute because the other common enteropathy in cats is lymphoma.
Yes, indeed.
So I'm assuming there's, or maybe I shouldn't assume, is there any role for manipulating the microbiome in lymphoma treatment? Because we tend to focus on drug therapy.
Yeah, that's a fantastic question.
Right?
It's a really good question. At the moment, we are trying to modulate the microbiome in patients with chronic enteropathy associated with a lymphocytic plasmacytic infiltrate. And at least in the cat, there appears to be emerging and increasing evidence that this inflammatory milieu is often
It's like a continuum maybe, right?
Precisely. It is a continuum. I think that's a good way of putting it. And I'm not aware of at least any results yet. Now, there are people looking at this. And I can't give too much detail at this juncture, but there may well be benefit to modulate the microbiome in an effort to see whether that can impact the severity of the lymphoma, or more importantly, or equally importantly, could I reduce the dose of my toxic drugs, prednisolone and or chlorambucil, when I juxtapose it with a transplant? And I think the answer is possibly yes.
It's a maybe.
For sure.
I think it's hugely intriguing, isn't it?
It is. It's very, very intriguing. But what I'll say, though, Susan, as well, is that, at least in our practice at UC Davis, I would say that the prevalence of small cell intestinal lymphoma, which is essentially the bread and butter of intestinal lymphoma in most of our feline patients, has surpassed that of inflammatory bowel disease. It really, really has. And again, is it a reflection of me seeing those patients in a biased environment where they've already been diagnosed or managed for their inflammatory bowel disease in the real world, and then they come to me because they now have recurrent diarrhea which did not respond to dietary manipulation or to prednisolone? It's possible, but we're also seeing some primary cases coming in that actually have small cell lymphoma from the get-go. And I think what I should really stress at this juncture too is that I don't want people to think that this is it's a black and white phenomenon, meaning it's either IBD or it's either lymphoma. Because if you took a cat to surgery or even to necropsy and you obtained multiple full thickness biopsies along the length of the intestinal tract, beginning at the proximal duodenum all the way down to the distal ileum, you could find an impressive number of cats that have histopathologic features of IBD, not far away from regions of bowel that actually have confirmation of lymphoma.
All right, Stan, thanks for a wonderful first podcast that we have here. I think we try to keep the podcast 25 minutes, and know you want to keep on talking forever. We have lots of topics, but I can tell our podcast family that we'll be back in 2 weeks with Dr. Stan Marks, talking even more about the things that interest you, cats only. And thank you, Stan, for being here.
It's a real pleasure, and I want to thank you both for this incredible opportunity. I look forward to coming back in 2 weeks' time.
Indeed. Thanks, Stan.
Yeah, you're doing a great job.
Awesome.
So
thank you so much.
All right. Thanks.
Thank you.
The opinions of this podcast are those by Dr. Susan Little and Dr. Yola Kerpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @PerPodcast. Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Yola Kerpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Yola works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX.